Welcome to the Deep Dive, your shortcut to being well-informed on the crucial topics shaping our world. Today we're tackling a really significant and growing challenge in healthcare, diabetic ketoacidosis, or DKA. This is a life-threatening complication of diabetes, and it's unfortunately becoming more common. We're talking hundreds of thousands of ER visits, hospital days every year. And managing DKA, well, for a long time, it's demanded really intensive resources, often pulling patients into the most critical care settings.
That's right.
Traditionally, getting DKA under control meant a continuous intravenous, an IV insulin infusion. And that almost always came with an admission to an intensive care unit, an ICU, or maybe another highly monitored setting.
Exactly. High resource use.
But what if there was another way, maybe a method that's just as safe, just as effective, but less invasive, maybe even more comfortable for the patient?
Right.
And could it potentially free up those precious ICU beds for others who, really need them most?
That's precisely our mission today. We're taking a deep dive into the latest research. We're comparing this traditional continuous IV insulin with subcutaneous, or SQ, insulin, specifically for managing adult patients with mild to moderate DKA. We'll explore the evidence, and we'll look at a fascinating approach called the SQuID protocol.
So if you're navigating modern healthcare complexities, or maybe you're interested in patient outcomes, or just curious how medical practices evolve, well, this deep dive offers you a clear understanding of a potentially pretty significant shift in DKA management. Let's get to it.
Let's do it.
Okay, let's unpack this. We've said DKA a few times. What exactly is it for listeners maybe familiar with diabetes but not this specific complication?
Right. So DKA, it's a really serious condition. It happens when your body just doesn't have enough insulin.
Okay.
Insulin lets blood sugar, glucose, into your cells for energy. Without it, your body gets desperate and starts breaking down fat for fuel instead. And that process, it produces high levels of blood acids called ketones. So doctors look for a specific triad. 1, uncontrolled high blood sugar. 2, increased ketones in the blood. And 3, metabolic acidosis. Basically, your blood gets too acidic. It's a true medical emergency.
A real emergency.
Yeah.
And because it's so critical, that standard treatment, the continuous IV insulin, it's always meant high-level care, right?
Historically, yes. Absolutely. Imagine the demands. An IV insulin drip needs constant adjustment, fine-tuning. You need frequent blood glucose checks, electrolyte monitoring, making sure everything stays balanced. All of this means a very low nurse-to-patient ratio, often 1-on-1, maybe 2-on-1.
Wow.
And it demands a highly monitored setting, like an ICU or an ED resuscitation area. You can't really manage that safely on a typical general hospital floor because of the staffing and that intense monitoring required.
That makes perfect sense. So if DKA is getting more common and each case needs this kind of intensive care, what are the real-world impacts? That sounds like a system under stress.
It absolutely is. The increasing incident, it nearly doubled in the U.S. between 2003 and 2017. It translates directly into more ICU admissions.
Doubled. Wow.
Yeah. And this really contributes significantly to overcrowding in EDs and ICUs, which, we all know are already stretched thin.
Yeah.
And there's a huge financial burden, too. There's a comparative study, I think, from 2018 in Canada that highlighted this really starkly. DKA hospitalization costs were just dramatically higher in an ICU setting, averaged about $20,428 Canadian dollars.
20,000. Compared to what?
Compared to a step-down unit where it was just $6,484 CAD.
That is a massive difference.
Huge difference, not just in cost, but potentially in patient comfort, too.
That cost difference alone is, well, it's astounding. It really makes the idea of a less intensive approach seem incredibly appealing.
Exactly.
So given that burden, the core question really becomes, could subcutaneous insulin offer a viable alternative? Is it equally effective? Is it safe? Especially for maybe the less severe cases of DKA.
That's the million-dollar question, isn't it?
Yeah. What's the biggest hurdle then? Is it just clinical evidence or are there system issues too?
It's a bit of both, really, but the clinical evidence is definitely starting to push the needle. What's fascinating is that researchers have been looking into this for a while now.
Okay.
And a recent systematic review and meta-analysis by Al-Nuaimi and colleagues, published just this year, 2024, did a fantastic job synthesizing all the current literature. They looked at both randomized controlled trials, RCTs, and observational studies. It gives us a really comprehensive view on this exact question, SQ versus IV insulin for DKA.
Okay, so thinking like a learner, wanting that quick takeaway. What's the headline from Al-Nuaimi's work? Is SQ insulin truly as good? What's the bottom line?
The most compelling insight, I think, is pretty clear. For mild to moderate DKA, these subcutaneous insulin protocols are proving to be just as safe and effective as the traditional IV method.
Really, just as safe and effective.
Yeah. The review included a really substantial body of evidence. We're talking 6 RCTs and 4 observational studies, over 8,600 patients in total. And they were primarily focused on these mild to moderate DKA cases.
Okay.
And their findings on safety and efficacy, they're quite compelling. The meta-analysis found no significant difference between SQ and IV insulin in several really key areas.
Like what?
Well, for instance, the time it took to resolve the DKA, how long until the condition stabilized, virtually identical. The mean difference was just 0.17 hours. Tiny.
Wow.
And also, no significant difference in all-cause mortality. In fact, there were no deaths reported in the RCTs at all. And the one death in an observational study, that was attributed to sepsis, not the DKA treatment itself.
So it wasn't the treatment method.
Exactly. Now, the quality of evidence for mortality was rated low, but that's likely because there just weren't enough deaths to analyze statistically, which is actually, a good thing for patients.
Right, that makes sense. What about side effects, like low blood sugar?
Good question. Hypoglycemia, that's dangerously low blood sugar. The analysis showed no increased risk with the subcutaneous insulin. The risk ratio was 1.02, basically the same as IV.
Okay.
And the quality of evidence for that was moderate, which gives us a pretty good degree of confidence.
And potassium levels, that's always a concern with insulin.
Yeah, hypokalemia, low potassium. There was limited data on that, but one study they included actually observed more episodes in the IV group.
Oh, interesting.
Yeah, but we need to be cautious there. The overall quality of evidence for hypokalemia was very low, again, mainly due to limited reporting in the study. So definitely need more research focused on that specific outcome.
So the headline is pretty clear. For the right patient, SQ insulin looks clinically just as safe, just as effective.
Yeah.
But what about that huge cost difference we talked about? The resource issue. Does this SQ approach actually help free up those hospital beds?
This is where it gets really impactful, especially for how hospitals operate. Now, it's interesting. The overall meta-analysis didn't show a statistically significant difference in hospital length of stay across all studies combined.
Ooh. That seems a bit counterintuitive.
It does at first glance, yeah. But if you dig into the individual studies within that review, some of them did report significantly decreased length of stay for patients treated with subcutaneous insulin.
Ah, okay. So variability between studies.
Exactly. For example, one study by Balili et al., they observed a significantly shorter hospital stay by an average of 6 days in the subcutaneous group.
6 days? That's huge.
It is. And another one, Stur et al., found a median length of stay of 3.4 days for 6Q versus 6.1 days for Thavi, specifically IV without an initial bolus dose.
Right.
So these individual findings, they're strong signals of the real potential for impacting hospital efficiency, even if the overall average in the meta-analysis kind of smooths out those effects.
Okay, so the aggregate data is promising, but the individual studies show real potential. How does this translate into, an actual plan for doctors and nurses on the ground? Is there a specific protocol that puts this into practice effectively?
Absolutely. And this is where a validated approach like the SQuID protocol comes in. SQuID stands for subcutaneous insulin in DKA.
SQuID, okay.
Yeah, and it provides very clear, very structured guidance for using SQ insulin alone in these cases.
How does it work? What are the specifics?
Well, the SQuID protocol is, as I said, highly structured. It starts with really careful candidate selection. It's designed specifically for patients with mild to moderate DKA.
Okay, only mild to moderate.
Yes. Specifically those with a serum bicarbonate level that indicates blood acid levels greater than 10 millimol and a pH, the acidity measure, greater than 7.0 if it's measured.
Right.
But crucially, patient selection is paramount. There's a very clear list of exclusion criteria.
Like what? Who is not a candidate?
Okay, so patients with severe DKA are out. Also, those with end-stage renal disease, congestive heart failure, pregnancy, certain high-risk heart conditions, euglycemic DKA, that's DKA with normal or near-normal blood sugar, sometimes seen with certain drugs like SGLT2 inhibitors, anyone with altered mental status or any other really critical care issues. They are not candidates for SQuID. This is absolutely key for safety.
Makes sense. You need to be sure the patient is stable enough for this approach. So what's the actual insulin plan?
For the insulin regimen itself, it typically starts with an immediate dose of basal-glargine, that's a long-acting insulin, followed by rapid-acting insulin Lispro given subcutaneously.
Okay. And the monitoring, is it still intensive?
It's frequent and meticulous, yes. Point-of-care glucose levels are checked every 2 hours.
Every 2 hours.
Yep. And electrolytes every 4 hours. The insulin Lispro dose is initially zero point 0.2 units per kilogram, given subcutaneously if the blood glucose is over 250 milligdl. Then that dose is reduced, halved actually, to 0.1 units per kilogram once the blood glucose drops below 250. And at that point, intravenous dextrose, basically sugar water, is also started to prevent the blood sugar from dropping too low.
Got it. Any other safety checks?
A critical one. Insulin is not given unless the serum potassium level is at least 3.5 milli-EQL.
Right, to prevent dangerous drops in potassium.
Precisely. Low potassium can seriously affect heart function. So that's a key safety check. The whole protocol continues until the anion gap, which is another measure of the acid-base balance, falls to 16 or lower. That signals the DKA, the excess acid, has resolved.
That level of detail, the precision, it makes it clear this isn't just, a simple swap. It's a very carefully orchestrated plan.
Exactly.
And having such a clear protocol, it sounds like it could really impact how hospitals operate. What does the real-world data show us about SQuID in action? Does it work outside of controlled trials?
It's very encouraging, actually. There was a real-world study by Griffey and colleagues in 2023. They looked at the SQuID protocol in an urban academic emergency department.
Okay.
And they showed some very positive operational impacts. For instance, the median ED length of stay, how long patients spent in the emergency department, was significantly shorter for the SQuID group compared to the traditional IV insulin group.
How much shorter?
By about 3 hours. It was 8.9 hours for SQuID versus 11.9 hours for the traditional therapy group.
3 hours less in the ED. That's significant for flow.
It really is. And that reduction was consistent across different comparison periods in their study.
What about getting admitted to the ICU? Did SQuID reduce that?
So in the Griffey study itself, the trend was towards lower ICU admissions for SQuID patients, but it didn't quite reach statistical significance in their specific analysis. And this is really compelling what's been reported from the center where this protocol has been used more extensively. There, the ICU admission rate for non-severe DKA apparently dropped dramatically.
It's dramatic.
From 54% before they implemented the protocol down to under 21% after.
From over half down to about a fifth.
Exactly. Think about that impact. You're more than halving the number of non-severe DKA patients needing an ICU bed. That demonstrates a massive positive shift in resource use in a practical, real-world setting.
That's a huge reduction. But, for doctors and nurses who are so used to that intensive IV protocol, how do they get over maybe the instinct that more care is always better care? Is there a psychological hurdle here?
That's a very perceptive question because, yes, there absolutely can be. There's often a deeply ingrained belief, that the ICU means the highest level of safety and attention.
Right.
Moving patients out of that environment requires, a cultural shift. It needs a high degree of trust in the protocol itself and also in the training provided to the general floor staff who will be managing these patients.
So it's not less care.
No, exactly. It's not about providing less care, but rather different care that is still highly vigilant, better suited and appropriately resourced for these specific mild to moderate DKA cases. And what's particularly noteworthy from that Griffey study is that the SQuID patients were managed on a general medical unit.
Not even a step-down unit.
Right, a general medical floor.
Yeah.
This really reinforces the potential for de-escalation of care without compromising safety. These patients got effective treatment without tying up those critical ICU resources. And safety-wise, the Griffey study found no statistically significant difference in needing rescue dextrose for hypoglycemia between the SQuID and traditional groups. Adherence to those 2-hourly glucose checks was also high.
So connecting this to the bigger picture, the benefits seem really clear. We're talking crucial resource optimization, freeing up those ICU and ED beds that are just so scarce.
Right, critical and crowded systems.
Then those considerable cost savings you mentioned earlier, managing DKA outside the ICU obviously leads to substantial reductions there.
Huge financial relief potential.
And, most importantly, for the right patient, these SQ protocols are proving equally effective and safe. No increase in adverse outcomes compared to IV insulin. It really reframes what better care might look like sometimes.
Yes. Exactly. It's not just about efficiency, it's about matching the intensity of care to the patient's actual needs. That benefits everyone involved. Think about the nurses, too. While they still need to be vigilant, it shifts the focus a bit from constant IV tweaking to a, perhaps, more patient-centered subcutaneous routine.
Right. Frees up time.
Yeah, frees up valuable time and often allows patients to be more comfortable. Maybe even sleep better without constant alarms and checks associated with an IV pump in an ICU setting.
It sounds like we're moving from a kind of one-size-fits-all ICU-level emergency approach to something more like precision medicine, even for common conditions like DKA.
That's a great way to put it.
But this raises an important question. What are the caveats? What are the challenges to rolling out something like SQuID more widely? It sounds great, but no medical change is ever completely simple, right?
Absolutely right. And the biggest one, we have to keep stressing this, patient selection is paramount.
Right. Back to the exclusion criteria.
Exactly. These subcutaneous insulin protocols are not for everyone. Patients with severe DKA, critical comorbidities like, say, an active heart attack or severe heart failure, or those unable to communicate symptoms, maybe due to altered mental status, they are explicitly excluded.
And ignoring that could be dangerous.
Very dangerous. Ignoring those criteria could lead to serious adverse outcomes. That's why the protocol is so strict on who qualifies. You have to get that right.
Okay, what else? Implementation challenges.
Yes. Even those outside the ICU, the SQuID protocol still requires that frequent monitoring. We talked about glucose checks every 2 hours, electrolytes every 4 hours.
Still pretty intensive.
It is, and that can still be demanding for some general medical floors, which aren't always staffed or set up to handle that level of intensive observation alongside their existing patient load.
So it needs system buy-in.
Definitely. Successful implementation requires significant education, training, and real buy-in from all the hospital teams involved. That means ED staff, hospitalists, ICU teams who might be consulted, and then, of course, the nursing staff on the floors. It's a system-wide change, not just a memo.
And research gaps. Are there still things we don't know?
Yes, there are. The systematic review highlighted that most studies focused on mild to moderate DKA. We have very little data on using this approach for euglycemic DKA or DKA triggered by different things. And there's a clear need for larger randomized controlled trials, ideally with longer-term follow-up, to really confirm the optimal dosing strategies and maybe refine those patient selection criteria even further. So it's a very promising path, absolutely, but one that still requires ongoing, rigorous study and very careful stepwise implementation in practice.
Okay. So we've explored some really compelling evidence suggesting that for carefully selected patients with mild to moderate DKA, subcutaneous insulin protocols like SQuID offer a genuinely safe and effective alternative to that long-standing standard of continuous IV insulin. It's not just theory. The data shows real-world improvements in how patients do and how hospitals operate.
And this isn't just, a clinical curiosity. It really represents a significant opportunity. We're talking reducing healthcare costs, improving operational efficiency, like decreasing ED and hospital length of stay, and critically freeing up those vital ICU resources.
Right.
All without compromising patient safety.
Right.
It's a powerful example of how more nuanced medical care, tailored care, can make a huge difference in system-wide capacity.
So the shift seems to be happening, but it's clearly a nuanced one. It depends on having robust protocols, a really collaborative healthcare team, and maybe a willingness to embrace new ways of thinking about care intensity.
Well said.
The implications for patient care and resource management are potentially enormous. So as you, our listener, reflect on this deep dive, what stands out to you? As medical knowledge keeps evolving, how do we strike that balance? The balance between the efficiency and resource-saving potential of innovative treatments and the absolute need for rigorous evidence and super careful patient selection. And maybe thinking even broader, how might similar protocol-driven approaches transform how we manage other common resource-intensive conditions in the future?